Good morning, everyone. Welcome to Grand Rounds. As our usual tradition, we present a research study to everyone here in the community to see what's going on at MHIF. And I think this study that I'm involved in is timely since we're talking about cardio-obstetrics, as this condition of chronic microvascular dysfunction really affects a lot of women. And this study is testing the hypothesis that this endothelial progenitor cell marked with called CD34 that we've used in other studies successfully may help improve patients' angina due to chronic microvascular dysfunction. And as a surrogate for chronic microvascular dysfunction, we use the coronary flow reserve, which can be obtained either by MyoView PET, MRI, or invasively using in the cath lab using adenosine to see what the increase in absolute coronary blood flow is, the ratio between baseline and with a vasodilator. So we're currently started this study. Again, it really involves, there's a lot of women with this condition, and we're also doing a lot of microvascular testing now in the cath lab. So if you have patients with chronic chest pain with normal epicardial arteries or no significant coronary disease, and you think they may have microvascular dysfunction, then please consider enrolling in this study. Thanks.
Is this on? Yep. Okay. Good morning. I'm Retu Saxena. I'm one of the cardiologists here. Let's see, escape. And I'm going to welcome Dr. William Wagner, who is my partner, my mentor, and my friend. Together, we make up the co-directorship for our cardio-obstetrics program. I want to thank our sponsors, Janssen Pulmonary Hypertension and Canixa Pharmaceuticals, who are sponsoring Grand Rounds this morning. Bill and I are going to talk about cardio-obstetrics, and we're actually going to talk about it a little bit differently than you would think. We're going to talk about it as a niche in women's cardiovascular health, so very timely, Dr. Travers, thank you. We'll talk about the scope of the problem. Where are we actually right now with our statistics and what's happening? Some solutions, and primarily what we're doing here at Allina Health. And then I really wanted to spend a little bit of time talking about a call to action and what the future, I think, of cardiovascular obstetrics should be and could be. Bill and I, unfortunately, have no disclosures. So for those of you that don't know, March is Women's History Month. And so I thought, why not start with a slide of the history of the advancement of maternal and reproductive health? We don't have a pointer, do we? Okay, that would be great. So if we look at some key points in time, the NIH Office of Research on Women's Health opened in 1990. 1990. FMLA was actually passed in 1993. The risk scores that Bill and I use, CARPRAG was developed in 1997. The WHO Cardiovascular Classification System, which is the big risk score that we spend the most of our time thinking about, was actually developed in 2011. And then I want to point out the year 2018. In 2018, the US government passed its Preventing Maternal Deaths Act. So 2018, not that long ago. Most of you who've heard me talk about cardio-obstetrics have seen this slide. This is the maternal mortality rates between 1987 and 2016. One of the problems with US maternal mortalities is the way we measure our data. We've had a lot of debate about how we measure data. But more recently, our data is very cleanly measured, and actually maternal mortality shows up on death certificates. And so again, I point out the year 2018 as the year the US passed its Act for Preventing Maternal Deaths Act. This was just published in February, this and the MMWR from the CDC, looking at the maternal mortality deaths between 2018, 2019, and 2020. So as you can see, despite our decision to help prevent maternal deaths in this country, we've just continued to have an escalating rate of maternal mortality, primarily seen not just in non-Hispanic white women, but overwhelmingly in women of color and women of Black or African American ethnicity. So we're not doing better. We continue to have increasing maternal mortality. We are, unfortunately, the leading country with maternal mortality deaths in this country, in the world. So when you look at developed nations, we do twice as badly as the next numbered country, which is France and Canada, where they're at about 8.6 or 8.7 per 100,000 live births. The United States, and this is from 2018, is sitting at about 17.4 deaths per 100,000 live births. When do these women die? Well, about less than half die actually during pregnancy or the day of delivery. The majority of these women are missed, and they die in that first 45 days postpartum. And so again, that fourth trimester, that time right after the baby comes out, is really key for prevention in these maternal mortalities. And then I liked this slide because it demonstrates kind of the change over the historical time periods. So in 1987, 1990, hemorrhage being way up here, leading cause of death. And what we've seen over the changes in the last few decades is the thing that's been climbing the most, so cardiovascular conditions right here, this has been increasing. And now cardiovascular conditions, hypertensive-related issues are the leading causes of death in the United States. And so again, 2007 to 2016, if you can see, a third of our pregnancy-related deaths are due to things that I take care of in my general cardiology clinic day in and day out. Things associated with congenital heart disease, ischemic heart disease, cardiac valvular disease, hypertensive disorders, and then congestive heart failure, both HFrEF and HFpEF. And so again, overwhelmingly in this country, the causes, the etiology of these deaths are things that we do day in and day out as cardiologists. So this was just published in February. Jack Gadd et al. Looked at the temporal trends of the incidence of mortality and cardiovascular events in pregnant postpartum women. It's a difficult slide, but panel A is total in-hospital mortality. The black line are Black women. The green line is Asian and Pacific Islanders. This red line is white women, and this, oh gosh, blue line, I think it's blue, is Hispanic women. This is total in-hospital mortality. As you can see, acute myocardial infarctions, again, things we deal with on call day in and day out, is upticked and going up in everybody but the Asian Pacific Islanders. I'm going to skip over panel C, which is stroke, pulmonary embolism, and then I wanted to point out peripartum cardiomyopathy. It really is the thing that we all worry about, and it's maintained its level of incidence and prevalence over the course of decades. So Bill and I, and we've said this many times to our patients, we say this all the time in clinic, we say this all the time when we do talks, we really do think first pregnancies should be utilized as stress tests. And it helps us to identify not only people who are at risk for maternal mortality, but those individuals who would benefit from future prevention for cardiovascular disease. And so why is that? Well, pregnancy is a stress test. Our cardiac output goes up, our stroke volume goes up, and our heart rate goes down. Because of all of those hormones that Bill knows far better than I do that are made by the placenta, we do see a decrease in total peripheral resistance, and therefore our blood pressure does not start to rise until about third trimester. But after the third trimester, our blood pressure actually ends higher than it did prior to pregnancy. And I want to point out that, again, it's that first 45 days. It takes up to 45 days, usually 6 to 8 weeks, before the heart goes back to our preconception or baseline state. And so it takes a while for women who are normal adapting to pregnancy to shift all those fluids and get our circulation back to normal. Those women who maladapt, it can take longer. And again, this is where we see our maternal morbidity and mortality during labor and then within that first 45 days. So I didn't want this to just be a very sad talk. I wanted to talk about and point out that so much has been done historically about trying to prevent maternal mortality and point out states that have done it well. So AIM, I think, started in about 2013. It was ACOG and the Health Resources Research Center nationally that came up with a data-driven maternal safety quality improvement. I'm not going to go through all of these. I wanted to point out, though, that there were multiple different societies involved in trying to decrease maternal mortality. States have their own maternal mortality projects and plans. Everybody is involved. But most recently, what's happened is the ACC, the American Heart Association, just this last month with its call to action paper that just got published by Catherine Lindley, and its kind of outline for what we should be doing taking care of these women, and the development of cardio-obstetrics programs. So if we look at this temporally, the thing that's new is the cardio-obstetrics program and thinking about things in a multidisciplinary format. So states that have done it well. California, this is the highlighted state of the state that actually has decreased its maternal mortality over time. And they've done a tremendous amount of work insofar as they are the state that everybody tries to act upon. They have a toolbox. It's called the California Maternal Quality Care Collaborative, or the CMQCC. And what they've done is they've looked at their deaths. They've evaluated them in great detail. And they've looked at how many of them could have been prevented. And what they found is actually the majority of these deaths that we see in women, 90% of all deaths, could have been prevented. And if we look up here for cardiovascular deaths, about 92% of them could have been prevented. And then I'll throw in that almost all the preeclampsia or eclampsia-related deaths could have been prevented. What they found is the number one cause for what was missed is actually a provider-based factor, and it's a delay response to clinical warning signs. So I wasn't going to do a lot of medicine. Bill's going to do the medicine part of our talk. But if you leave with nothing else, we say in clinic that pregnancy symptoms are heart symptoms. Heart symptoms are pregnancy symptoms. I ask my 97-year-old male patient these questions in clinic. Are you short of breath? Are you having chest pain? Do you have orthopnea? Do you feel your heart racing? Do you have elevated blood pressure? Is your oxygen level low? Simple symptoms that cardiologists ask our patients day in and day out. If we paid attention to them and potentially used an algorithm, which we're all very good at using, and looked at those symptoms and some vital signs, we could have identified 88% of women who died. So this is from the CMQCC. They actually went backwards and applied this algorithm to the women that died in California. 88% of those women could have been saved. And so if you get nothing else from this, nothing else from my talk, take this home. It's as simple as paying attention to symptoms and then having them evaluated. And we feel that they should be evaluated in a multidisciplinary format. And so this is cardio-obstetrics. It truly is a village. It's not just Bill and I. It's Joellen Moore. It's Dr. Gornick. It's Dr. Lesser. It's our other maternal fetal medicine colleagues, Dr. Lofton and Dr. Bigelow, Dr. Kalickia, and Dr. Loischinger. It's some of our OB colleagues. It's our anesthesiologists, Ben Reynolds and Dr. Milstein. We have a CT surgeon that works with us, Dr. Moody. We have our own pharmacist, Greg Laffin. We have our social worker, Pam, who's just phenomenal. And then really the backbone of our program is our two nurse coordinators, Cassie Longtine and Rachel Gobar. They make sure that they herd us. That's number one. I think the hardest thing is to herd our physicians. But they also make sure that every one of those women that we take care of know to call us with any change in symptoms. So Bill, myself, or Cassie, any of us could go ahead and respond quickly and not make sure that those women feel supported through their pregnancy. So what do? We actually evaluate them from preconception. We risk score them, which I think is the most important thing we do. And we manage them through pregnancy. We come up with labor and delivery planning for every single one of our patients. And then we see them postpartum, which we'll talk about a little bit as we talk about the changes in our hypertension order sets. We follow them through the 4th trimester, that really scary phase where fluid shifts are happening. They can go back to the ER. And then we see them long-term and try to evaluate interpregnancy risk for their next pregnancy. So As we look at the multidisciplinary approach to peripartum care, we really do spend a lot of time thinking about symptoms of pregnancy as cardiac symptoms. We believe that every woman who's pregnant who has any cardiac symptoms or is at risk for cardiac disease should be evaluated. And pregnancy as an etiology of those symptoms really should be a diagnosis of exclusion, and that women with pregnancy-induced complications need close follow-up and evaluation. These are our risk scores. I'm not going to go through them in great detail. Zahara has primarily been used for congenital heart disease. CarPreg-2 replaced CarPreg. It actually works well and has a great ROC for identifying those women at risk. And then the one that we spend most of our time acting on, what we're going to present our research about, is the Modified World Health Organization classification. We take that and we use that to help determine who's going to get seen, how frequently they're going to get seen, where they should deliver, and what evaluation that they're going to need based on symptoms. So I'm going to turn it over to Bill, and Bill's actually going to present our data from our program.
Thank you, Retu.
Thank you.
Everybody can hear me okay? Does that sound okay? The other group of people I just want to also mention that Retu may not have mentioned is part of our cardio-obstetric program is our advanced practice RNs. And certainly Heidi and Jill Coggins and Nicole and Ellen, they're all a part of this program. And they really are just an intimate, if you will, part of the overall success. You know, any program that gets developed, the one thing you want to, if you will, devil in the details is, are we making a difference? That is, we expend energy, the three-legged stool, time, resources, and money. Is it really worth it, that is, to put all of this effort in? So as Retu and I really were trying to put this together, we said, you know, we're now about 4 years into the infancy of this program. If you will. The embryo's been created, the program has been delivered, as I put it, and now we're looking at, if you will, our patients in infancy, and are we, in fact, really making a difference? So what we really wanted to put together was looking at essentially two different eras. We wanted to look at, in general, 2016 to 2017, where in fact we did not have necessarily a bona fide multidisciplinary CVOB program. And then compare that to our most recent data of 2018, 2019, and try and again look at risk scoring classification, stratifying for each of the, if you will, 1, 2, 2, 3, 3, and 4, utilizing the MHU classification, which we think, at least now, probably not only nationally but internationally, is the most accurate classification in terms of the overall risk of adverse cardiac events in pregnancy. We utilize CarPreg-2, again, as an adjunct, but by and large, again, the WHO classification, probably the most important. Zahara, as many of you know, was really initially designed by the German group of adult congenital heart disease, and it's really more in focus to congenital heart disease than it is to acquired heart disease. So we use each of these scoring systems, but again, these are the two that we really have tried to rely on in terms of making sure that we're comparing apples to apples and oranges to oranges. So you can see the breakdown here, if you will, between our CVOP program and again, prior to the time that we had that. And if you look at the demographics, again, the typical comorbidities that we talk about, coronary artery disease, hypertension, those with congenital or familial hyperlipidemia, cerebrovascular disease, renal disease, pulmonary heart failure, cardiac arrest, aortic dissection, which has become a major issue, particularly in the setting of bicuspid aortic valve, which I think if we look at any one particular valve lesion that appears, if you will, to have the least interest to a lot of people and the least follow-up of which makes Retu and I a little crazy about even general cardiologists who look at women with bicuspid aortic valves, and we'll see you, in another 5 or 6 years. We've obviously, I think, turned the corner, as you'll see, in terms of the frequency of assessment that really should be done. And again, you can see cardiac valve insufficiency, cardiac valve stenosis really are the major differences, if you will, in terms of the two particular comparisons. So again, we looked, if you will, at the outcomes, shall we say, looking at our data, looking at parity, obviously the number of pregnancies that they had, looking at the age mean, and you can see the age of pregnancy has certainly increased, as many of you know, over the past few years. Average age of pregnancy now, if you will, even for first pregnancies, can be, if you will, over and above age 30 to 35. So obviously they are delaying, if you will, pregnancies. And again, that it increases their potential risk of developing acquired heart disease, or particularly cardiovascular disease and hypertensive disorders that will arise in pregnancy. And again, you can see the ancestral breakdown that we have there. So we also looked, if you will, at medications prior to pregnancy, those who are on anticoagulation, those who are on an antihypertensive or antiarrhythmic. Again, you can see there's a fair amount of antidepressants which are used in this particular patient profile. We also looked at those medications during pregnancy, and again, you can see the majority of the anticoagulated patients are those with mechanical heart valves that we have, although we have some that require anticoagulation because of a history of thromboembolic disease. So what did we find? Well, our CVOB patients were more racially diverse, 34% non-white versus 24% of the comparison group. And I think, again, simply highlights the concept that we are still not doing a very good job in our patients, if you will, of color. There are social dynamics, obviously, we need to work at. Access, if you will, we need to work at. But this patient population, again, continues not only to have the majority of cardiovascular disease and pregnancy issues, but they have still the highest maternal mortality within this particular profile. There was no difference, if you will, with regard to parity, age, or Hispanic ethnicity. Our CVOB group had higher rates of valvular heart disease, again, primarily due to unrecognized congenital heart disease in this patient profile. As we know, particularly in the state of Minnesota, we are no longer primarily blonde-haired, blue-eyed, and Scandinavians. We are a melting pot. And many of the patients that, in fact, we acquire, so to speak, are those who show up in the emergency room with symptoms related to pregnancy, are then discharged home, who then return another 2 days with worsening symptoms, and then the appropriate evaluation and diagnostic imaging is performed, and you find out that they have unrecognized congenital heart disease. And obviously the changes that occur in early pregnancy, as Retu and I have pointed out, by the time they are 10 to 12 weeks, their heart dynamics and adaptive changes that need to occur to maintain a normal pregnancy, even within the first 12 weeks, has increased over 30%. So obviously, if they have issues related to adapting, so to speak, this is where they begin to get into trouble. Again, our CVOB patients had higher cardiovascular disease risk scores based upon the WHO, as well as our CARPREG-2 evaluation. Antiplatelet and antihypertensive use was higher during pregnancy, again, among CVOB patients. And again, the majority of the antihypertensive issues related to not only, if you will, pre-existing hypertension, but obviously the development of hypertensive disease in pregnancy, primarily preeclampsia and or eclampsia. So again, we looked at patients experiencing specific tests and events during the pregnancy. and we look at the important key issues by and large, where we looked at the number of tests in each of the particular areas. Echo, obviously, we looked at in terms of comparison. We looked at our rhythm issues related to Holter and Zio patch. We looked at all of our different echo, cardiac CT, cardiac MR, and looking at our ED visits and our inpatient admissions during pregnancy, which were relatively the same. And you can see the cardiology complications during pregnancy were, again, roughly the same. We look at our delivery and our post-delivery outcomes, and again, the important key by and large that we want to highlight is that inpatient or OD visits in the first 6 months were, in fact, significantly reduced. And as the two of us talk about the fourth stage of pregnancy or the early postpartum issues related to hypertensive disorders, as well as issues related to our attempt to reduce readmission, which is the #1 issue related, if you will, to this patient profile. And it's a major issue not only to the quality of care they get, but it's an issue related to hospital cost. And Retu can go over the hospital costs, if you will, of readmission, which is not negligible as we go forward. So I think as we put this together, and obviously we're hoping we'll finalize the paper and hopefully people will find it acceptable for publication. The concept of a CVOB program works. It has benefit. Again, it isn't going to prevent all of the particular issues, but it has a tremendous benefit, if you will, in access and bringing patients who desire or who really need this quality and level of care. So again, the final results, women who received care in the OB program, they had more cardiology tests during pregnancy relative to pre-program controls, as we would anticipate. They experienced about a half-day longer length of stay, again, by and large, because we were very aggressive about managing their criteria for discharge, as you will see, as it relates not only to their cardiac function, but, if you will, to their control of their hypertension. They had obviously more telemetry during pregnancy. We're more likely to see one of us, if you will, postpartum through our CVOB postpartum program, and they were less likely to have inpatient ED visits in the first 6 months. Again, goes to quality of care, goes to, if you will, the stewards of financial well-being, if you will, of they and our program. There was no significant difference in cardiology complications during the pregnancy or postpartum time period. So we think that our CVOB patients were certainly more closely monitored by cardiology as well as us during the pregnancy as well as postpartum. In a multidisciplinary non-university program, as we have developed, coordination of care during the pregnancy may have contributed to fewer postpartum emergency visits and readmissions.
We only have one microphone. Did you find another one? Oh. I'll see if Bill wants to do that. So we also wanted to focus a little bit of our time talking about what's changed with hypertensive disorders of pregnancy at Allina Health. So for those of you who are cardiologists listening, there are distinct definitions for gestational hypertension. Blood pressure greater than 140/90 on at least 2 occasions, and severe range hypertension in the OB population is greater than 160/110. If it happens after 20 weeks of gestation, we call that gestational hypertension unless it's severe range or comes with severe features, we call that preeclampsia. If it occurs before 20 weeks of gestation, it's considered chronic hypertension. And then, of course, the worst outcome from adverse pregnancy outcomes and future cardiovascular risk is those individuals who have chronic hypertension who end up then with superimposed preeclampsia. So we know that preeclampsia is bad acutely, leads to all sorts of changes, pulmonary edema, right ventricular strain, left atrial enlargement, increased LV wall thickness. It's bad for the heart acutely. It's actually bad for the heart chronically. It leads to an increase in wall thickness over time, remodeling that's adverse, and then a change in diastolic dysfunction. over time, there's a long-term excess CV risk in these women who have hypertensive disorders of pregnancy. This is actually from the UK Biobank data, which was actually published in 2019, looking at not only do these women have worsening hypertension over the course of time, they have an increase in coronary artery disease, heart failure, which I'll come back to, aortic stenosis, and mitral regurgitation. So this is years out. We see that all of these women have an increasing burden of cardiovascular disease. And what's sad for me, and again, this is a completely different talk, is that chronic hypertension, of course, accounts for 1/2 to 2/3 of the excess cardiovascular risk. But in this country, only about 1/3 of women who actually have hypertension by ACC/AHA goals are being appropriately treated by guideline-based medicines and getting them to goal. But that's a completely different talk. So this was just published by Minhas in Hypertension, looking at one, the odds ratio of preeclampsia by different ethnicity, and then the intra-pregnancy time period complications that are cardiovascularly related. So this is during that pregnancy admission. So of course, the odds ratio for Black women have more overwhelming burden of preeclampsia, as well as Hispanic women compared to white women as the reference. Interestingly, and I do find this very fascinating, Asian Pacific Islander women actually have a decreased odds ratio compared to white women, but they have probably the worst risk of developing pulmonary edema during their incident pregnancy. So if you look over here, this is deliveries without pregnancy-induced hypertension. Those women with gestational hypertension, again, just the elevation in blood pressure to about 140/90, there is a slight increase in arrhythmias, slight increase in acute renal failure, just a slight increase in congestive heart failure. But those women who present with preeclampsia during that admission for their delivery, they are more likely to develop, of course, peripartum cardiomyopathy, seen far more in women who are Black or African American, and then Asian and Pacific Islanders, more apt to develop congestive heart failure, pulmonary edema of any course. We are now understanding that diastolic dysfunction is probably the most likely cause of this, and there is an entity of HFpEF of pregnancy, which is very different than peripartum cardiomyopathy. Acute renal failure, and then for the electrophysiologists, they're also more apt to develop arrhythmias during their course of pregnancy. And so again, more and more are we going to be seeing these women, and it's really important, I think, to help develop treatment plans and algorithms to fix adverse pregnancy, hypertensive disorder of pregnancy, to avoid adverse pregnancy outcomes. This was a study that was just published at the end of 2021, looking at incident admission for heart failure with preserved ejection fraction within 10 years after your incident preeclampsia. So you had preeclampsia, got discharged, and then you came back within the first 10 years for heart failure with preserved ejection fraction. So I think our heart failure doctors need to know that this is a risk factor. Preeclampsia, gestational hypertension, is a risk factor. So controlling for other multivariates, the hazard ratio for preeclampsia and eclampsia for an incident admission for heart failure preserved ejection fraction within 10 years post-delivery is about 2.09. Of course, being Black, hugely impactful. And then again, how much of this could be mediated by just treating women to blood pressure goals the way we should be treating them, i.e. based on guidelines? How much of this could have been abated? We'll see. Postpartum hypertension and readmission, one of our #1 reasons that these women get readmitted is actually because of their blood pressure. If you happen to have a blood pressure of greater than 140/90 within 24 hours after discharge, your odds of readmission is about 1.98. If you have 2 blood pressures greater than 140/90, your odds of readmission is about 3.14. The majority of women who are readmitted are in that first 5 to 7 days postpartum. And so because of all of this data, Dr. Hanya, the hypertension work group, Dr. Wagner, Heidi Sanis, we decided to rewrite ALINAs across ALINA. This went live in February, order set for postpartum hypertension management. So I'm going to let Bill tell you about our new orders. Oh, I should have passed off the other microphone.
Okay.
So this is our fun, oh, that's my pager. Do you want that?
No.
No? I tried.
You know, one of the myths that I certainly are more familiar with than you all are over the years is, you know, blood pressure issues in moms, they're young, they're healthy, they just get better. You don't really need to be aggressive about their management. And I think as Retu and I, and unfortunately our patients have demonstrated to us, that myth is simply not true. These people have not only the potential to develop acute issues related to cardiovascular disease. As Retu and I have pointed out, this patient profile, in the absence of aggressive management, are faced with the potential of lifelong cardiovascular disease and an issue related to shortened lifespan and all of the other potential, if you will, comorbidities that go along with heart disease. So this really, I think, was the impetus, not only necessarily for us, and we thank, if you will, Alina, MHI, the foundation, that gave us the opportunity, the time, and the resources really for us to begin to put this all together. And all of my partners at Minnesota Perinatal, as well as Suresh and those that we have mentioned, really felt that this was going to be a tremendous benefit, if you will, not only to us, but to the patients, but to, if you will, our organization in general. So obviously we began to look at, you know, who is at risk, how could we stratify, and how could we manage, if you will, aggressively, this fourth stage of pregnancy that is from the time of delivery, if you will, through the first 12 weeks, which as Retu and I have suggested, you know, you're still pregnant within about the first 12 weeks physiologically and organ function, if you will, and all of the particular changes and adaptive changes. It takes about 12 weeks, if you will, for those to go back to baseline. Again, the major goal was the fact that our postpartum goal was to maintain blood pressure less than 130/80 before discharge. Obviously, there is some pushback to this because you have the push-pull. What was one of the major, if you will, metrics over the last 5 years with length of stay. The longer these patients are there, the more expensive it becomes. So there was, if you will, this kind of push-pull dichotomous issue that to be aggressive in managing these patients to an appropriate blood pressure to reduce their likelihood of readmission, and we felt their readmission was much more important than extending their length of stay, if you will, over that particular time period. So obviously, one of the other, if you will, mechanisms was we began to use longer active antihypertensive agents and recommended initiating oral antihypertensive medication for persistent blood pressure greater than or equal to 140/90. And again, equally as important as we all know, lifestyle modification, education, and the key here, appropriate follow-up care over a short period of time. I'm not going to necessarily belabor this slide. It looks a little busy, but again, it really is an algorithm that I think is important. And what we did was we stratified blood pressure, if you will, and we also stratified, if you will, ethnicity and ancestry. Most of you are much more familiar than many of my colleagues, if you will, were about the issue related to the ancestral issues of those of color, whom in fact labetalol and the other beta blockers are less effective, if you will, in managing their hypertension as opposed to calcium channel blockers. You know, within the OB world, if you had hypertensive issues, you gave them labetalol or you gave them a combination beta blocker. In fact, in those with renal dysfunction, in those of, if you will, Afro-American or Afro-Caribbean population, they really work very poorly in managing. And so we obviously set up new algorithms, not only stratifying their blood pressure, but also stratifying their ancestry to pick, if you will, the most salient medication, as well as to attend to their other comorbidities, particularly issues related to renal dysfunction. And again, you can see what we tried to do was come down each row, if you will, in, shall we say, typical algorithmic form, and again, make changes or make adjustments to their antihypertensive regimen such that we could achieve 24 hours, if you will, of a blood pressure that was at 130/80 or less. Again, our goal, if you will, particularly in those of which we suggested as hypertensive urgency or emergency, that is the blood pressure, if you will, 160/110 or greater sustained for 15 minutes. Again, we attempted to move towards, again, more longer acting, if you will, antihypertensive in this particular management profile as opposed to the IV. The only time, obviously, as we came down our algorithm that we moved not only from oral antihypertensive regimen to a more aggressive IV antihypertensive regimen and transfer, if you will, to our OB-ICU program here was that if they had sustained blood pressures, if you will, over the first 1 to 2 hours, above 160 and over 110 with aggressive oral antihypertensive therapy. Again, our goal was to target systolic blood pressure, if you will, within the first 24 hours, and those with hypertensive urgency and or emergency, again, 25% reduction, if you will, within the first 2 to 4 hours to reduce the potential likelihood of precipitating ischemia in those who may have chronic hypertension and who may have a different set point, if you will, such that we are not aggravating somebody with known chronic hypertension who requires that pressure head. And again, we feel that this particular postpartum hypertensive order set has now been well received. It has gone live in February, if you will, and is now in force. Again, our other recommendations, Retu is going to go over BNP a little bit with you, but we think it's an important marker, if you will, for the threshold of cardiac volume loading. We initiate diuretics rather rapidly with a BNP of greater than 100, and standard education again. Early warning signs we went over, when to seek emergency care, and then again, an outline for the long-term risk of cardiovascular disease and follow-up. BP monitoring and follow-up visits after discharge. Obviously, the program, they return to us within 48 hours. They all go home with blood pressure cuffs, appropriately calibrated, and they are trained to utilize them. And again, managing them, hopefully, in the outpatient setting, if you will, reduce cost, but yet doesn't reduce their access, if you will, to oversight and professional change. Again, this particular clinic is now up and running, and it is quite busy, thankfully, if you will. And I think the results, as we will see, are forthcoming. So I'm just going to turn the last part of this over to Retu. Yeah, go ahead.
And then you can keep going. Is this on? So I do want to put a shout out to Heidi Sanis and go back 1 second. So this 12-week postpartum clinic is actually a risk prevention clinic. It's a CVD risk prevention clinic that's being housed in Mother Baby. How fantastic is that? The whole point being interpregnancy risk, cardiovascular disease risk, hypertension, insulin resistance, obesity, not only impacts future cardiovascular disease outcomes, so we're thinking prevention in the future, but it actually impacts the second risk of having a hypertensive disorder or pregnancy or adverse pregnancy outcome. So this is very novel, this program. We are, as opposed to giving everybody Lasix, which this study looked at in hypertension last year, where they just discharged everybody with Lasix, we are actually following BNPs. It's actually part of the hypertensive disorder guidelines. Everybody gets a BNP who has a hypertensive disorder or pregnancy diagnosis. And if their BNP is greater than 100, they get started on diuretics. If it's greater than 300, they potentially get a cardiology consult and an echo. They should get an echo first. If that echo is abnormal, cardiology should see them, with the idea of trying to find these women sooner, especially women who are at risk for HFpEF and HFrEF, PPCM being the most likely cause. So for those of you who've not looked at BNP in pregnancy is actually highly predictive of those women who are going to be have adverse outcomes. It does go up in pregnancy, but it usually doesn't hit a threshold of 100. Now, have we had patients who don't follow this data? Yes, we have. They usually have HCM or an other actual true myocardial disease process, but the majority of our patients, whether it be valvular disease or hypertensive disorders of pregnancy, even even aortic valvular stenosis follow this pretty well, and we can tell exactly when they're going to start having difficulties. So we do use BNPs a lot in our CVOB practice, but we also are starting to use it now in our hypertensive disorders of pregnancy to help determine who's going to need diuretics. So we're going to end, Bill and I, with the where we think the future of CVOB should be. And for those of you who don't read this literature, Dr. Lindley put out a very nice paper it was exactly titled A Call to Action. It was in circulation. It was just published 2022 in February, so last month. And it piggybacks on the circulation article that was published at the end of last year by Mehta et al., looking at what the future of CVOB is. And Garima Sharma also just published a paper at the end of 2021 looking at CVOB training for us in the future. And so again, it's kind of a multi-pronged approach in how we change maternal cardiovascular mortality. Of course, multidisciplinary care, we are there. We have multidisciplinary care. Our patients are seen in telemedicine visits. It's the Brady Bunch, for those of you who are old enough to remember the Brady Bunch. It's the Brady Bunch view of they have the pharmacist, myself, if we have a fellow with us, the MFM and our nurse coordinator, and then the patient. It's actually well received, and it actually expands our reach. We've seen people from North Dakota, we've seen people from South Dakota, we've seen people from Wisconsin, and so we do have a large catchment area. But I think it's going to be really important as we see that we need to start cross-training OBs and of course MFMs to understanding the cardiology world. So the Society of MFM just had its meeting, and I think a day or half a day was Cardio-OB. For those of you who are going to ACC, we're not quite at half a day, but we'll get there, where CVOB is highly highlighted as lectures. And training us in understanding the pathophysiology of pregnancy. We need policy reform. We need sex-specific scientific research. Right now, there is no research in women who are lactating. So, you know, we apply these guidelines and we're thinking about treating blood pressure, but we don't know if our drugs are okay. We go by historical data, but we don't research this. So why is this important? Well, first off, I want to point out that the heart disease and stroke statistics in 2021 had an entire chapter, first time ever, on adverse pregnancy outcomes. So it's important because it's timely. For those of you who look at numbers, it's important because 313,000 hospital discharges had hypertensive disorders of pregnancy. The 73,485 visits for hypertensive disorders of pregnancy, gestational diabetes, you can see their numbers, preterm birth, small for gestational. These are not the babies, these are the moms that get readmitted. Pregnancy and postpartum care in this country accounted for $71.3 billion as cost to the House of Medicine. And then complications, what Bill and I are trying to avoid and change, relates to about $5.5 billion for hypertensive disorders of pregnancy in the postpartum period. And then for preterm birth, it's $28.2 billion. So for no other reason, I mean, of course, from my standpoint, it's the maternal mortality. The reason things need to change is, other than the maternal mortality rates and readmission rates, is the cost is huge to the House of Medicine and to healthcare. So this is from Dr. Sharma and her stance of developing CVOB as training programs. We have these new subspecialties. We have prevention, imaging that's not yet board certified, as opposed to the subspecialties that exist, such as interventional EP and heart failure. But I think what we'll see as we move forward is there's going to be COCATS requirements for training in CVOB and potentially women in heart disease as well. I think we do a good job of understanding the disease spectrum. We've developed a pregnancy heart team, or CVOB team. We are going to keep working on improving research and registry data, and I'm going to show you that in a minute. And then I think we need to think about improving training and education of our fellows and our future doctors in this field. And it's not just cardiologists and other cardiac subspecialties. I had an OB call me the other day about our new order sets and say, I went into OB because I didn't want to manage hypertension. Unfortunately, Now we need to have our OBs cross-trained the other way to manage hypertension. We know that 66% of women see their OBs as their primary care provider. We need our cardiothoracic surgeons. I pointed to Dr. Moody earlier, but we need our cardiothoracic surgeons well-versed in this. Our pediatric cardiologists, such as Dr. Hahn, we had neonatologists or pulmonary hypertension specialists. And we need to spread this information out, especially to our internists and our family medicine doctors, because a lot of times they see this. And our ER doctors, I can't tell you the number of patients that we've taken care of. They're marked CVOB patients. They go to the ER and they leave with a diagnosis of bronchitis when they actually have heart failure. And so because they're young women, of course they can't have heart failure. They have heart failure. So in terms of research, this hopefully, no pun intended, will be us this summer. We are hoping to be part of this NIH-funded, it is actually going to be a trial looking at CVOB programs. Bill and I did all our paperwork and turned it in. It's sitting at the NIH desk right now. It will be the largest study looking at heart outcomes in pregnancy in the United States. We've had ROPAC, which is European, looking at primarily congenital and now aortic. This is gonna be all comers. It'll have acquired, arrhythmogenic, and congenital patients, looking at not only how the women and the babies do, but also how the programs do. And so each program is gonna be stratified by whether or not they meet all 5 components for a CVOB team. We meet all 5 components, so yay us. But we're gonna hopefully be part of this. We're just waiting to find out if it gets funded. So there's a lot of research coming in this and being done. And then we need policy change. I think those of you who know that Mosey's doing this work on implicit bias and bias reduction, I think this is absolutely needed across all of those subspecialties, because the women who tend to die are women of color. We need maternal health equity, improving awareness, preconception counseling, which we do really well. You know, my favorite comment is the congenital heart patient is told, you can't get pregnant. They leave that office visit thinking that they're unable to get pregnant. That's very differently worded than you should not get pregnant, which is, you know, pregnancy is not going to be very, very good for your heart. And that has been something that has been told to women forever. We need to not have any issues about discussing contraception with our patients of childbearing age, especially if you're seeing them in cardiovascular clinic. We absolutely need to expand postpartum care and remodel our healthcare delivery. For those of you who want a really good paper to look at the CIRC policy paper that just got published. I'm kind of impressed because, again, we passed that law in 2018 and our maternal mortality rates have continued to increase. So CVD is the #1 cause of maternal morbidity and mortality in the United States. I think cardio-obstetrics teams, or we think cardio-obstetric teams with risk assessment delivery planning decrease maternal morbidity and mortality. We had no mortality in our cohorts, which is great. Really, if you leave with nothing else, pregnancy and postpartum symptoms are cardiovascular symptoms. They really should be assessed. And then policy, research, and education changes are needed to impact our woeful mortality rates. Anything else? Oh, you have a microphone.
Yeah.
Any other thoughts?
Well, you know, one thing I have to say, at least to this audience, is as I am nearing the end of my career, if you will. Retu never wants me to leave, and other people don't want me to leave, but I am nearing the end of my career. And I have to say that, you know, you look back at people that had a tremendous influence, not only on your medical acumen, but the issues related to how to see patients, how to talk patients, all the patients that I have been given the privilege, if you will, to have the opportunity to take care of. And certainly Retu is one of those people. Carol sitting in the back is probably been more important in mentoring my understanding of cardiovascular surgery and disease in the pregnant patient. And I can't thank Carol enough for essentially taking a fledgling under his wing, if you will, and helping him, along with Ben. John Lesser sitting in the middle, again with Kelly Hahn, have, if you will, taken a fledgling ultrasonographer and created such great interest in echocardiography that I feel as comfortable in interpreting echocardiography as I do in looking at fetal echocardiography. And again, to really the foundation here, who really have had a tremendous impact on not only the care that we have been given the privilege to do, if you will, and, if you will, the resources, as well as all of my, if you will, partners who may be, if you will, on the Zoom meeting today, and Minnesota Perinatal, about the ability to not only take this program, I hope, and continue it when I am, if you will, transitioned to another, if you will, area of interest, but hopefully they will take this program and go forward. So I thank you all, you know, from your particular area and Retu for giving me the privilege to be a part of your team going forward.
Does anybody have any questions? Should I hand you this mic?
Yeah. All right. So we actually have the audience microphones on, so that won't be
guess you
necessary.
can ask
Okay, that's great. I can tell you that we're extremely lucky to have such a fine, high-risk OB, and to have Retu take the interest and move this forward. It's fantastic. I also was part of this more early, and so I want to understand your two groups that you're looking at, so we can try to parse out what's really the added benefit that we've seen so far, and what else do we need to do?
So we did, so initially the demographics piece, we just looked at the two separate groups. So the advent of this women seen in CVOB versus women that were seen by cardiologists, not part of the CVOB program before its invention. So 2016, 2017 were just women who were pregnant who got a cardiology consult.
So I think the biggest value for the cost is the follow-up ability. In other words, if you're someone with little resources and now you have a phone number to call and that person gives you a right answer, boy, that would be just invaluable.
The outcome data, though,
Yeah.
that we presented in terms of readmission, those were matched by MWHO criteria. So we took that historical.
The risk is the same.
Yep.
And what you're offering is expertise, but you're, and at least in my mind, you're offering something that we lack tremendously, and that's access.
Yep.
Access and some information.
Yes.
Well, and like I said, and I pointed it out, our nurse coordinators are the backbone of this program.
Yeah.
And when you look at
And
CV
our APRNs.
and our APRN
They really are.
and our APRNs, when you look at CVOB programs development of, and you look at, there's 5 actual things that CVOB programs need other than the multidisciplinary care. It's the nurse coordinator that sets those programs apart, and the APRNs. And so you're absolutely right. You're absolutely right. It's the access in that postpartum stage. We train all of our women really well to call in. And most of these women do get follow-up visits with Heidi or Jill or who am I missing? Ellen,
Nicole.
and Nicole within about 2 to 3 days post-delivery. That's set up in our delivery planning. We say stay in the hospital for 72 hours, and then of course within 72 hours have a follow-up visit. So that's part of that delivery planning. Yes.
Thanks to both of you, and I'm sure we'll find something for you to do, Bill. It's particularly cruel to add a 4th trimester to pregnancy, I think. But can you comment on the fact that you didn't see any change in the complication rate? Why do you think that was? I mean, that was, I believe, one of the things that you showed that.
You mean within that time period in the 4th?
Yes.
Well, I think there are several factors. I think one, maternal age has a tremendous impact, if you will, because if you even take a look at the age 40 and over patient profile, they're much more prone to already, if you will, have issues related to type 2 diabetes, issues related to hypertension, other particular comorbidities, where again, 30, 40, 50 years ago, the average age of pregnancy was 20 or 25 years of age or even younger. So they're starting with the potential to already have underlying comorbidities. The other major contributor in the United States is BMI. In my existence, I would have never thought that 2/3 of the patients that we see with comorbidities in pregnancy are now all related to BMI. I mean, it is a tremendous issue related to our society in general about nutritional information, nutritional awareness in a relatively affluent middle school, and I won't tell you which one, within, if you will, the suburban community. They actually looked at BMI of the middle school between 6th and 9th grade. And over 1/3 of all of the kids already met criteria for obesity. And 2/3 of that 1/3 met criteria for morbid obesity with a BMI of 40 or above. So you can see, we are actually the only developed nation in the world where, if you will, lousy nutrition leads to high BMIs. Most of the places in the world, poor nutrition leads, if you will, to asthenia. That is, they have difference. So when we begin to look at the issues related to this particular time period, we're dealing with a much different population. And the other thing I will say is, which is a different talk, I happen to have the privilege of being asked to be part of the Jill Davis, if you will, congenital heart talk at Children's coming up in April. We have more people today, adults living with congenital heart disease, than we have kids. So the success story of, if you will, adult congenital heart disease, as for both, shall we say, the medical and surgical and interventional, if you will, is that these kids now are living to the concept of pregnancy. And that is a whole different talk and a whole different world outside of acquired heart disease. But that is the major issue with our influx, if you will, of people from around the world who are now coming here. They have unrecognized congenital heart disease, or they have, if you will, unrecognized acquired heart disease that they had such poor access. So in answer to your question, we actually have more individuals with comorbidities, which put them at a greater risk in that, if you will, first 12 weeks. But I think awareness is a big deal, and I think that's what Retu and I, making people aware that just because you appear to be relatively healthy and pregnant moms just got better, I think, again, is a myth that we simply, if you will, have diffused. Not all, but some.
And I'm assuming you were asking about our complications. We weren't different. So there were cardiology. We had complications. We just weren't different in the two groups. And again, we had no deaths, so it was primarily heart failure driven. So sorry.
That was my question.
I know. Sorry. Yeah.
Thanks so much for this great talk, Bill and Retu. So nothing gives me more anxiety when I'm on call than getting a mother-baby consult in the night, just because I think, I perceive this as the stakes being so much higher, and then there's still, to me, there's a lot of murkiness about what medications we can use. So when I see a pregnant woman with hypertension, what's your algorithm? You did a nice algorithm for postpartum, but what do you start with to treat
labetalol
hypertension?
first.
Okay.
Labetalol is perfectly safe, has been used forever, okay? And remember, labetalol doses, TID dosing, and there's a ton of it you can give, right? Nifedipine second, hydralazine. So a lot of times we switch moms from ACE, ARBs, ARNIs who have heart failure to a hydralazine and Iserdil. Perfectly safe as third line. So, and you can do IV hydralazine.
And there's all this, so labetalol, beta blocker, and there's all this concern about beta blockers and growth retardation. Is that just
Jay, that's
old
It
school?
was a tenolol, which we don't use.
And it was a tenolol, but the fact of the matter was that if you actually look critically at the literature that first was described in, the majority of those individuals were put on that particular line of medication at that time, which is now 40 or 50 years ago, as an antihypertensive. They already had a risk for growth restriction or small for gestational age based upon the fact that they had underlying chronic hypertension. So most people have suggested that this fear of beta blockade and its utilization either for arrhythmias or for heart failure, or for those with cardiomyopathy, or those, if you will, where a beta blocker, a pure beta blocker, would be indicative, should have no fear of issues related to the concept of issues related to pregnancy. The one thing that we always tell our neonatologists if they're on a pure beta blocker is it does relate to a degree of neonatal hypoglycemia. So our neonatal, if you will, compatriots always need to know that this fetus obviously has been exposed to a pure beta blocker. But I will tell you, Coreg, Carvedilol, I mean, they are our mainstays for cardiomyopathy.
We use metoprolol, toprol, Coreg
Yeah.
in clinic.
No problem.
No
Okay,
problem.
great.
We have the conversation, and he has the conversation with the moms, but we do mention it. I will say that I think our OB colleagues do a good job while the placenta is in place. And so a lot of times it's going to be magnesium and IV medicines. What we've learned and what we're learning, and stay tuned because we'll present that after we've been up and running with our hypertension guidelines for a period of time, because we're going to look at it pre and post the adaptation, because this is new. There aren't a lot of hospitals and systems that are using as tight blood pressure controls in this country for postpartum hypertension. But what we've learned is it's that postpartum period where, again, we believe that they're young, healthy women and they should be able to handle blood pressures of 160, so we should send them home. What we've learned is that that's where the comfort level is lacking in our OB partners. And so and the new drugs like enalapril, which I know you're very comfortable using, but our OB colleagues are less so comfortable using. And so it's going to be that change that I think you'll get more calls on these days. The other thing that we've learned, which we're just seeing anecdotally, and so I can't wait to look at it, is that when Heidi and Nicole and Jill are APRNs that see these patients back in postpartum hypertension clinic, they're still hypertensive 2 weeks out, 4 weeks out, 6 weeks out. So this idea that the blood pressure goes back to normal, a week after we deliver, completely wrong. At least anecdotally, wait for it. We'll tell you next year what we find.
Right.
But I have a feeling that these women, that we're going to unmask a lot more chronic hypertension than we realized. I have a handful in my clinic that started pre-order set that I'm seeing, and we're now 3 to 6 months out, and I still have them on 4 or 5 drugs to keep their blood pressure controlled. These are young, quote unquote, healthy women who just had preeclampsia or gestational hypertension. And I think the other thing that we're going to see is that that distinction between gestational hypertension and preeclampsia is going to start shifting too. So it'll be interesting. I think this space is very, very fascinating. So don't be scared. And then the other thing that I learned early on is I trust my partners in MFM. They'll tell me about the baby risk. And so really, you just have to manage the medicine. And if you ever have any questions about drugs, Greg Laffen, it's Laffen, send him a note. He does all of our CVOB pharmacy stuff. Yes.
Yeah, so thank you both for that excellent presentation. We do have several comments and just one question online, so we would just take that one question. The comments are all relating to just perhaps the increased need for education surrounding this topic. So I think presentations like this are an important step in doing that. The question comes from Lisa Kirkland, who asks, should all women who intend more pregnancies be maintained at, I assume she's referencing blood pressure here, but less than 130/80 until they have completed their families?
So when you look at so there's an interval called interpregnancy. That is the interval between subsequent pregnancies. When you look at the risk of interpregnancy, and again, these are not huge studies. They're not the studies we're used to in cardiology, but there are studies that have been done. Blood pressure is implicated in future hypertensive disorders of pregnancy and adverse pregnancy outcomes. But as Bill was noting and saying, the number one indicator for who's going to have a hypertensive disorder of pregnancy that in that interpregnancy interval is actually obesity. So I would say, yes, managing blood pressure regardless should be guideline based, and the new normal is less than 120/80. That's been the new normal since 2017, which wasn't that new, right? That's 5 years. But the other thing, and this is what our 12-week postpartum hypertension prevention clinic is focusing on, and we're utilizing Alina's weight management services, is weight control. Turns out obesity is the biggest predictor of subsequent preeclampsia and eclampsia.
And heart disease and long-term cardiovascular disease.
Yep.
You know, again, I think one goal that I'm hoping we're going to meet, we've had a tremendous degree of success based upon Susan G. Komen and the issues related to, you know, the early diagnosis and treatment and outcome of breast cancer. However, unfortunately, recognize more women die every year of heart disease and cardiovascular disease than breast cancer, even though we have made tremendous inroads. So I think we still have a long way to go for issues, if you will, and awareness, and getting this out, if you will, surrounding the need for cardiovascular health care, if you will, of women who clearly, if you will, have a major focus here for all of us in terms of their overall long-term health.
Thank you guys so much.